Hello everyone and welcome to CK Med. My name is Clark and I'll take you through head and neck first video today. To start things off in the head,
some of the first things are more of the superficial aspects of this. So first thing, most superficial, is going to be what is known as your scalp and how infections possibly could spread. So the scalp has 5 layers, and they actually correspond to the word scalp, which is quite amazing. So if you look at it this way, S of scalp stands for skin. Then C is going to be your connective tissue. This is going to be your dense connective tissue. You have a lot of blood supply in there. What happens due to it being dense connective tissue, when you damage this or like cut it or whatnot, you actually end up bleeding out a lot in your scalp because it's dense, irregular connective tissue that's holding open your blood vessels. It's not allowing it to constrict due to its rigidity. So that's going to be your C layer. Next is going to be aponeurosis. It's just fibrous tissue that allows kind of sliding along. So this is the bottom layer of the top 3 that can slide along the bottom 2 layers. So SCA can slide along on top of L, which is your loose connective tissue. So this is a loose areolar layer. This is a danger area of your scalp where infection can spread easily throughout. And again, SCA slides around on top of L, and then right below that, it's going to be your P of scalp, which is your pericranium, which is just like periosteum that's surrounding your cranial bones. So those are the 5 layers of scalp. How blood supply goes through the bone or around the bone, we have 2 different types. We have diploic veins, which diploic veins are just veins that are from the inside of the skull up into the bone of the skull, but however do not cross across the bone. It just only stays within. So this is blood supply or venous drainage that comes out of the skull, draining that area into the dural sinuses into the skull. Next is going to be your emissary veins. So this is a venous drainage of the lower layers of the scalp that can cross through the skull and then into the dural sinus. This is also important for the aspects of infection spread, how they can travel through diploic veins, or I'm sorry, emissary veins to cross over from outside of the skull into the skull, and possibly hindering a lot of different things inside of the head. So different forms of infection. So there's this triangle or danger area of the face, starting just above the nose and cornering down on either side of your cheeks at the ends of your mouth. As you can see by this gentleman over here, has that triangle drawn over him. And although it's very rare that this actually occurs, but it is a danger area. Trying to figure out how an infection can spread up into the cavernous sinus, which is inside the skull, and a lot of important structures such as your internal carotid and several cranial nerves actually pass through the cavernous sinus. So those are possibly affected via infection if they spread via this. And most likely it's going to be through your superior ophthalmic vein that does drain this, which is right here. So superior ophthalmic vein is going to be draining everything above as far as venous drainage does of your face in this triangle. And that's going to be your superior ophthalmic. Possible others is going to be your inferior ophthalmic if it's coming maybe from your nose or from your cheek or your upper lip. If it comes from anywhere else, maybe down on your lateral side of your face or under your or inside the mouth. And if it's going to go into the cavernous sinus, then you're thinking of the pterygoid plexus, whereas that can drain into there. So now this is very, very high yield. Definitely go and check out other pictures other than the ones that I have provided here as to what epidural, subarachnoid, and subdural hematomas look like. This is so high yield, you're going to get it all over in neuro, over and over and over and over, and never ever hear the end of it. This is something that will arise even in later terms, which I haven't even gotten to, but I've heard that they, for some reason, love this like no other. So Epidural hematoma is usually caused due to a damage to the pterion, which the pterion is a portion of your skull that is a fusion place of your parietal, your frontal, your temporal, and your sphenoid bones that fuse together in this one space, and it's kind of weak. And right behind this pterion is an artery known as your middle meningeal artery. This comes right off your maxillary artery, which is off your external carotid artery. So this is a very high pressured artery that can bleed very quickly if this damages. And key words that you'll hear from this is very quick onset, so sudden is the word that you'll probably hear. They'll be unconscious for a certain amount of time. Then they'll come, they'll wake up. It'll be known as a lucid interval. Then slowly progress within 30, 40 minutes, 50 minutes after they have awakened again, that they'll start to lose consciousness and deteriorate again, and this could lead to their death. Why this is because you immediately damage your brain, lodging it a little bit to the side and shifting it so that you lose consciousness. But then what happens is you regain that consciousness, but you start bleeding into this space, and this is what is under your pericranium. So you have this space where this blood kind of pools under this pericranium, and it's kind of held. It's held in place very tight to the bone, so it forms this hourglass or this biconvex mass. It looks just like this, or lemon-shaped is another way that they describe this. And this is your epidural hematoma. So this is in your epidural space. Inside your skull, you have two layers of dura, your external and internal dura. And those actually form your sinuses, which we'll discuss in a little bit. But this is outside of the dura will form this kind of loopy thing. It's actually not, under your pericranium. It's actually your dura. This is known as your epidural hematoma. This one will come arise very quickly. This leads to, as far as neuro, possible uncal herniation damaging your midbrain. You can have eye problems. Cranial nerve 3 is going to be damaged, leading to your eye being out and down, damaging parasympathetics, so your eye will also be dilated too. Certain details which you'll uncover in neuro. Subarachnoid hemorrhage, so this is often also due from arterial, but this is usually due to like a Berry aneurysm, which arises from the anterior communicating artery, which will go into the circle Willis in just a few minutes. But this anterior communicating artery swells. It's a very tiny, weak thing that if this swells and builds up and pops, if this ruptures, these arteries are now in the subarachnoid space, so with your CSF. So wherever your CSF is floating, this blood can pool, and this leads to very, very extreme headache. Why? Because you have nerves that pick up anti-inflammatory signals that are in your blood. In your blood, you have anti-inflammatory, inflammatory signals, all these different molecules that your CSF doesn't have. So whenever this gets introduced into the CSF, your nerves kind of go crazy, and it causes the most severe headache the person has ever heard in their life, or thunderclap headache. It has a tree-like or spider-like appearance, and you can see this. It follows along all the grooves of or your gyri and sulci of your brain. And so you'll also see it over here. So here's some blood right here. They could show it over on this side too. They might not show it here where it gives it away. Could show it over here, but then as you see in this picture, this is subdural, but you'd see it pooling in and making little fingers into the gyri of the brain. And so that gives it away that is actually subarachnoid as opposed to subdural. So now subdural is the last one. This is rupture of meningeal veins or bridging veins. Bridging veins is the key word there. This is where it's actually subdural. It's under the dura that you have bleeding. This is usually often in patients of elderly age, and it's usually venous structures that are bleeding. It doesn't build up a lot of pressure, but it does cause a lot of headache and a lot of bleeding into a space that shouldn't be there. They have fluctuating consciousness, and it's known as crescent-shaped. It's not smooth like it is here. See how this is very smooth? So this is epidural, very smooth, and this is kind of like wobbly. And this isn't the greatest picture, but it's crescent shaped, and you'll see it a little wobbly in some of the other images that you find online. So now a little bit about cranial nerves. I'm not going to go into super detail. I will be posting videos on cranial nerve 3, 7, 9, and 10 as far as their parasympathetic and main flow. But as far as the basics, you should definitely work on learning where these cranial nerves, or what are they called? What's 1 through 12? What are their names? Basics as far as what is their basic function, as well as if there's any crossing over in the brainstem, which you'll learn in neuro. But that'll help you at least to dive into further detail on these guys. And then what about deficit? Like if I damage a specific or break a certain part of the skull, maybe somewhere where a nerve exits, what are all the things that you're going to lose? Or what are the possible multiple choice? So head and neck is very complex. There's no way that you could do all of Gray's questions and just feel satisfied that you know the questions now for your exam, because they're going to be vastly different than Gray's questions. So definitely realize that now, because all they have to do is just change one word and it changes the answer entirely. And just simple as that. They have unlimited options really of asking any of these questions, because each one of these nerves does multiple things, except only a couple. And so it's very important to realize and be able to think clinically as well as critically in order to understand and answer any of these questions. So definitely take this very seriously. This head and neck and cranial nerves is insanely high yield, not only for anatomy questions, but also for your neuro. When you start learning more neurological pathways and functions and deficits that you'll come across with patients. So definitely learn these. These are some mnemonics. Some say merry money, but my mother says big brains matter more. So that's really sensory or motor or both that you'll come across as far as functions of each of these nerves. Don't waste your time really learning that. You're going to learn each of these individually. So obviously your olfactory for smell is sensory. There's no motor involved with smelling. So definitely understand that it makes sense. Optic, okay, it's just vision. There's no motor that goes into vision. So obviously it's sensory. So you're going to go through each of these and it's going to start to make sense as you piece them together. Definitely check out the other videos, though, that I will be posting for 3, 7, 9, and 10, as well as the exits and entrances of the skull and brainstem and stuff like that, to get a further grasp on all this. There is another resource I will be posting. It is the most amazing resource for head and neck cranial nerves. There's nothing that is better. It's from University of Utah, and it is cranial nerve tutorial. You can probably Google it if you can't find the link that I posted. And this video really takes you through each of the cranial nerves. You can light up each individual one by themselves and look at their paths. It describes all the fossa, foramens, and fissures that they pass through, as well as what type of fibers each of the nerves are carrying and the paths that they take. So definitely utilize that in coordination to your lecture notes, which are kind of basic. They're not super helpful and super repetitive, but that in coordination with other files that I have posted for your cranial nerve information. This will help further dive into details as far as function, because that Utah resource doesn't say, oh, this does taste on this region of the tongue or something like that. You want to get those details from lecture as well as those additional resources. But however, this is bare bones for cranial nerves. And here's some of a nice picture you can find online as well. Super helpful, kind of basic information as far as where these things go and function. I'm not going to go over this in detail for right now. So one important thing I will go over, though, and I will be describing this in the cranial foramen and fossa video, is understanding where the cranial nerves go through and exit out of the skull. So one of the important things is just to organize each individual cranial nerve. So we'll start up on the top. So cranial nerve 1 is your olfactory nerve. So olfactory is for olfaction or smell, and this is going to go to your nose. And how it gets those fibers down into your nose and exits the skull is known as the cribriform plate. The cribriform plate is a little porous plate made of the ethmoid bone that allows olfactory nerve fibers to go down and directly touch anything that comes into your nasal canal and can stimulate them so then you can smell. That's pretty much all you need to know for cranial nerve 1, is that it's the only one in the anterior fossa of the skull, and it exits out the cribriform plate. So anterior fossa, you have your middle fossa and your posterior fossa as well. So next is going to be your optic nerve. So your optic nerve has its own little canal that it can go out. So optic is going to be for your eyes, for vision. And this is your optic nerve goes through the optic canal out to the eye. And then the blood supply that follows along with this in the optic canal is going to be your ophthalmic artery. Following that is going to be your superior orbital fissure. It's right in the back of your eye. It's the main thing that all the nerves and everything for your ocular movements, as well as some of the blood supplies and everything that go through there for other things like your face and such, and venous drainage, is going to go through your superior orbital fissure. You definitely need to remember that cranial nerve 3, 4, 5, and 6 are nerves that go through the superior orbital fissure. Now for 5, it's specific to the V1 branch because you have 3 branches of trigeminal, but the first branch is the one that goes through the superior orbital fissure. And that's important for sensory on the front side of your face, the top of your nose up to your forehead, at the top of your forehead, the apex of your head. Next is going to be your foramen rotundum. So this is your round foramen. Rotundum means round. And this houses the maxillary nerve that travels alongside there, as well as the maxillary nerve, which is your V2 or 5-2, your trigeminal V2 division. So this is your maxillary nerve that exits through there. So V1 is known as ophthalmic nerve, V2 is maxillary, and V3 is mandibular. So it kind of describes where they go. V1 goes up by the eyes and the forehead. Maxillary is going to be your cheeks and your upper lip, and mandibular is going to be your mandible or your chin and your jaw. Foramen rotundum is where V2 or maxillary nerve travels through to exit the skull. Foramen ovale, which is going to carry your V3 division or your mandibular nerve, along with accessory meningeal and a few other things. So it actually spells out ovale when you're thinking of the foramen ovale. So let me write that. So you have ovale. So ovale stands for ovale. So this is going to be your foramen. And then everything that goes through this foramen is going to be described by these 4 letters. So first, V. Where did we see this V? Oh, that's right, V3 travels through foramen ovale. A is going to be your accessory meningeal, which we described here. Okay. L is going to be your lesser petrosal. So lesser petrosal is a nerve of parasympathetics that goes through the foramen ovale for the purposes of innervating reaching your parotid gland. So this is going to your parotid gland, which is a main salivary gland that you have on the side of your face. This is originated from a nerve known as your glossopharyngeal nerve or cranial nerve 9. So cranial nerve 9 has a little branch known as lesser petrosal, and that also passes for foramen ovale. So that's very important to know that if you damage or crack open that foramen ovale, not only will you lose your mandibular branch, so you'll lose some motor for mastication, for chewing, you'll also lose sensory of your jaw, except for the angle of your jaw, and your lower lip and everything like that, your chin. But you also will lose parasympathetics, so you'll have dry mouth because you can't innervate the parotid gland on the side of your face because you're going to damage that. And the last thing is going to be emissary veins. So we talked about those emissary veins of vein drainage that can go across the skull. Some of them actually travel right through foramen ovale. So now a little bit about the next one is going to be your foramen spinosum. So you have one thing that's important for this is your middle meningeal artery. So the way they actually reverse ask this question is someone comes in with a description of an epidural hematoma, which we discussed before, which then you're thinking middle meningeal artery, right? But they could put it as second order and asking which foramen did this pass through, and that's going to be foramen spinosum. Next is your internal acoustic meatus. So this is important for cranial nerves 7 and 8. Makes sense for 8 vestibulocochlear as it goes to the vestibule or balance center, as well as your cochlear nerve for hearing. But also your facial nerve goes through this, exits the skull via this way as well. Once the facial nerve gets into this internal acoustic meatus, it branches off into a couple parasympathetic fiber branches and special sensory, taste and stuff like that. But then it continues as its motor branch and exits via the stylomastoid foramen, which when we go over your skull video, definitely check that out because I'll show that. This foramen allows for facial nerve to exit and continue through the parotid gland and branching out into 5 branches that allow for facial expression control, those muscles of facial expression. So if you want to smile or frown or raise your eyebrows or wink or close your eye, that's going to be in need of facial nerve. Jugular foramen is another foramen that 3 nerves actually exit. It's going to be 9, 10, and 11, glossopharyngeal, vagus, and accessory. Spinal accessory is number 11. Now we've heard number 11 before in back and spinal nerves when we learned about different muscles such as the trapezius. So trapezius is innervated by this in addition to the sternocleidomastoid. What's weird about this nerve, though, is it comes off the brainstem outside of the skull. It comes up through the foramen magnum. So if you just imagine you have your skull, right? So this is the back of your skull, and you have this foramen magnum, okay? And your brainstem comes down a little bit like this, right? Well, this is actually where the nerve originates, is down here. And it actually ends up coming back up into the skull before then it exits the other hole with these 2 other nerves, which is your jugular foramen. So that's how this one kind of ascends. It's a little strange compared to the other ones. This is highly taggable for your lab exam, so definitely mark that and make sure you check that out when you go into lab so you don't miss that question. Hypoglossal canal obviously is for the cranial nerve 12, known as the hypoglossal nerve. So definitely don't mess that up. It's got its own little canal that it can exit out of. So now a little bit about blood supply. So this is known as the circle of Willis and vertebral and basilar artery supply. And so you can see the circle of Willis is this guy up here. Very, very tiny because your brain is actually not that large, but you have this very small blood supply on the ventral surface or the bottom of your brain, and it kind of goes along your brain stem. So the best part is understanding how each of these branches and pieces kind of come together in coordination with the cranial nerve. So before we get to the cranial nerves, let's go ahead and look at the circle of Willis. So remember we learned back in spinal nerves about the blood supply to the spinal cord. We have 1 anterior spinal artery and we have 2 posterior spinal arteries. And how those originate from are actually from right here. So you have 2 vertebral arteries which come straight off of your subclavian, because remember your vitamin C and D, so V is actually your vertebral arteries. So vertebral arteries come up, they do a little curvature and weird distortion before they start to give off this one right here. This guy here is very important. This is known as your pica, your PICA, posterior inferior cerebellar artery. So this supplies the posterior and inferior portion of your cerebellum. Also applies quite a bit of your spinal cord as well, which you'll get to in neuro as far as blood supply deficits. High yield for neuro, less high yield for this. But around this, we have our cranial nerve 11, which passes right here, if you can see this. Cranial nerve 11 passes right through here. So if we have an aneurysm of bulging out of this that could damage a nerve, you're thinking pica in coordination with accessory. So this patient won't be able to shrug their shoulders. They'll have difficulty turning their head because that's what those muscles do. Next is it's going to ascend, keep ascending as this vertebral artery and give off the anterior spinal artery, just one. It's going to fuse together on the anterior side of your spinal cord and go down to supply your spinal cord. If this gets damaged, you'll lose quite a bit of things, especially with sensory and such, but you'll get to that further in neuro as well. The vertebral arteries then fuse together and they come up. And now this fused big, giant, basic thing is known as your basilar artery, because this is the base of your pons. It literally sits right on top of your pons. And if you look at a picture of a pons, you'll never forget a picture of the pons, because the basilar artery sits right on top of it. It's a little bulge. It's the belly of the brainstem. So the basilar, or the belly of the brainstem artery, gives off the next main branch. And this one is so important. This is the anterior inferior cerebellar artery, or AICA, A-I-C-A. This is important because you can have aneurysms in different locations. If you have it close to the basilar artery, then you're really thinking about injuring cranial nerve 6. However, if you have an aneurysm more lateral or distal away from the basilar artery, then you're worrying about 7 and 8. So just think of symptoms. So 6 was your abducens nerve, which we didn't talk about the function, but abducens is important for lateral rectus muscle. So it's a muscle that moves your eye to the side. If you don't have this, then you can't move your eye to the side. So if you have it on the left side, then your left eye can't move to the left. Simple as that. If it's moved more lateral and you're hindering 7 and 8, so 7, that means you're going to have problems with your facial expression on your left face, or hearing out of your left ear, or you might have problems, or nystagmus. Your eyes might bounce back and forth. You might be very dizzy, hard to balance. You got to sit down or lay down. Problems like that. So that's going to be your AICA and coordination to those. So as this comes up, you give off your little pontine arteries that supply your pons, and then as you come up here, the next or last branch of your basilar is going to be your superior cerebellar. So we talked about posterior inferior, anterior inferior, and now we're at the superior cerebellar artery. Superior cerebellar obviously supplies the superior cerebellum. Also does a few other things. So if you have an aneurysm really close to the basilar artery at the superior cerebellar artery, you're going to damage cranial nerve 3. So this is known as your ocular motor, and this innervates multiple eye muscles, pretty much everything having to do with up, down, and medial looking of your eye. So if I want to look with both my eyes to the left, my right eye is using this nerve. So try that. Take both your eyes, look left, and your right eye is using ocular motor. So that's what that does there. So you'll have problems with that. Your eye will be out and down, and you also will have dilation because you have parasympathetics in there which constrict. If you lose constriction, you'll have dilation. Now if it's more lateral, way over here, bulging out on the posterior side of your cerebellum, then you can most likely damage cranial nerve 4, which is his trochlear. This only innervates one muscle, your superior oblique. So if you remember, like sulfate, SO4, it's going to be superior oblique for the 4th cranial nerve. It's going to be that guy, trochlear. Next, as we get up here, we get our posterior cerebral. So now we're in our cerebrum, not our cerebellum, but our cerebrum. So posterior cerebral supplied blood from the vertebral arteries. This is the last of the supply, really, that this does. There's a slight, tiny amount that goes through here, making this circle. But this supplies the occipital lobe and a lot of the medial surface of the brain, and quite a bit of your temporal lobe as well. And so that's going to be your posterior cerebral artery. If you have an aneurysm here, again, because cranial nerve 3 actually passes right between these, right here, then you're most likely going to damage cranial nerve 3 as well. Posterior communicating comes up on either side. You have 2 of those. And you have this big fat guy. So this actually comes in, does a little few twisting into the skull. It has its own little canal. And these are known as your internal carotids. So these are your internal carotids. They come in and supply your middle cerebral and here. So the blood supply from this region only does really this. But the blood supply from your internal carotid does the middle and anterior cerebral arteries. So internal carotid will come in tortuous, inside the skull, tortuous when you look at an angiogram or x-ray, angiogram. you'll see that tortuous inside the skull, not in the neck, but inside the skull. If it's in the neck and it's tortuous, you're talking about vertebral arteries. But if it's tortuous in the skull, then that's going to be your internal carotid and going to your middle cerebral or anterior cerebral. Then we have this little anterior communicating artery, and this is where we can have baryaneurysms. And guess what is right here? We have a nice optic chiasm. If this has a nice swelling, you're going to damage cranial nerve 2. So this is a baryaneurysm. We can also have baryaneurysm right here of the tip of the basilar artery, or baryaneurysm of the posterior communicating. So if these rupture, all these blood supplies are in our subarachnoid space. Don't miss that. That was on our neuro exam. I actually missed that question. It was so sad. But all these blood supplies in your subarachnoid space. So if they pop open, they're going to bleed there, leading to a subarachnoid hemorrhage or hematoma, which then that will lead to severe headache. So now a little basics, or more basic details as far as the parasympathetics. So parasympathetics are important in the skull for doing a few things. One of the first things is going to be constricting the pupil and increasing convexity of your lens so that you can look close. It's known as accommodation. And those are both going to be controlled by cranial nerve 3. Cranial nerve 7 it has parasympathetics that go to your lacrimation or tears. It also does your nasal and sinus mucosa and allows them to secrete a little bit so it's not dry. So your palate and your nose are not always super dry. And that's also from facial nerve. And then some of your nasopharynx as well. And then lastly, it also gives off innervation parasympathetically to submandibular and sublingual glands, those are salivation, and those are under your jaw, and those are very important. So if you have damage to any of cranial nerve 7 that's above one of these parasympathetic fibers, you're going to lose one of these functions. You're going to have dry mouth, or you're going to have dry eyes, or dry palate, or dry nose, or nasopharynx and stuff like that. They're going to describe it that way, and they're going to say, oh, where is this possibly damaged, or what's the nerve that's involved? Next is going to be your cranial nerve 9. So this is your glossopharyngeal nerve, and the parasympathetics travel via lesser petrosal. We talked about this. It goes out through foramen ovale and hops onto what is known as the otic ganglion, and that goes to your parotid gland. We talked about this, and this is another salivary gland. It's a huge amount of saliva that this gland secretes, and this is innervated by lesser petrosal parasympathetics from cranial nerve 9. Next is going to be your cranial nerve 10. Really the only important thing as far as head and neck goes for cranial nerve 10 is going to be your pharynx and larynx innervation for vocal tone, as well as allowing airway to be open and such, as well as sensory in that for cough reflex and such. There's not a lot, and it doesn't really do parasympathetics that much. It's mainly just for the innervation of those muscles. However, it does a little bit of the mucosa to keep those things a little moist, so it's not super dry and crackly all the time. So now on to a little bit of sympathetic innervation of the head. Sympathetics are quite simple, and they just kind of counteract the innervation of the parasympathetics from cranial nerves 3, 7, 9, and 10. However, sympathetics, again, arise only from T1 to L2, and they have to ascend up synapse in the cervical ganglion, which is located in the neck, and then they can fall along the arteries that come and supply any of these regions where the parasympathetics are going to go. So obviously it's going to do all of everything as far as all your skin and sweat glands and stuff like that, erector pili muscles of hair. But it's also important for innervating some of the basic things such as in your eye, like constriction or dilation, where sympathetics will do your dilation and parasympathetics will do your constriction of your pupil. Sympathetics do not affect accommodation or the reflexes of your lens shape. However, just the lack of parasympathetics being shut down, those parasympathetics being shut down will increase the stretch or pull on the shape of the lens. Sympathetic also travels up to different areas as far as salivation too. They also innervate sweat glands or salivary glands, but they do it to an extent to where the saliva is more dry and less mucousy as normal, or less watery. So as far as in the eye, you have or in the face, you have a greater petrosal, so that's parasympathetics from cranial nerve 7, and then your deep petrosal, which is your sympathetics. So don't get those confused. That's pretty much sympathetics for the face. It's not super complicated, but it just does what sympathetics usually do. So hydrocephalus. Hydrocephalus is an important concept, and you'll come upon it a lot in neuro content from the neurology department or neuroscience department. So we have a couple. We have non-obstructive and obstructive hydrocephalus. So non-obstructive means that nothing is blocking off necessarily any of these ways that our CSF is flowing. So how CSF flows is it originates inside the lateral ventricle. It gets secreted out and ends up flowing through the lateral ventricles from posterior to anterior. And in the anterior, it then goes through what is known as the foramen of Monro. And the foramen of Monro enters into what is known as the third ventricle. The third ventricle surrounds your hypothalamus, and your thalamus is on the lateral aspects of this ventricle. And then it carries down through this cerebral aqueduct. It's very thin. This is the most common place where obstructive forms occur, but this is again non-obstructive, so the fluid will come down here into the fourth ventricle, which is behind the midbrain, or the pons and the medulla, and anterior to the cerebellum. It kind of makes this space known as the fourth ventricle, and then there's exits through the foramen of Luschka and Magendie can exit out through there or continue down in the central canal of the spinal cord. So that's where all this CSF can flow. Once it gets down there, it can get reabsorbed back into blood and back around, or it goes around the brain and then can end up being reabsorbed. So what happens is in non-obstructive hydrocephalus, there's either a couple things that could happen. So it's obviously due to enlargement of all the ventricles, so all of them. It's not just certain particular ones. It's all of them are increased in size. It's usually due to obstruction in the CSF absorption. So you have these arachnoid villi or arachnoid granules that reach in or that reach out into the superior sagittal sinus. And the superior sagittal sinus, remember, superior sagittal sinus is made up of those two dural layers. So these arachnoids spaces with all this CSF reach out into here, and then this can start to leak out and get reabsorbed into the blood to then be filtered and then come back into this lateral ventricle and complete the cycle. If this gets obstructive, so for some reason it doesn't diffuse across, then that can increase the fluid inside the CSF space and lead to non-obstructive hydrocephalus. Remember, superior sagittal sinus, important for that. Now, obstructive hydrocephalus, often most common due to cerebral aqueduct blocking, is going to lead to some of these ventricles being built up in size. Most common, again, cerebral aqueduct, and it can lead to a backup of these. Remember, you have a small space of foramen Monro. If this gets blocked up, then your lateral ventricles only are going to be enlarged, the other ones will not be. If you have cerebral aqueduct, then your third ventricle as well as your lateral ventricles will be blocked up. And if it's in your central canal of your spinal cord or your foramen of Luschka or Magendie, then you're going to be building up your fourth, your third, and your lateral ventricles in size, and that will lead to hydrocephalus, obstructive form. Next is going to be some of the disorders that we have of the face and head and neck. So one of the first places that we discuss, and you're going to hear all about, is what's known as Bell's palsy. It's usually unilateral, and this is a condition where you damage facial nerve, cranial nerve 7, and damage the ability to do facial expressions. So patients will be drooling because they can't hold their cheek taut, they can't smile, they don't have any wrinkles on their forehead, they can't blink their eye on that side. A lot of problems, and that's going to be what is known as Bell's palsy. Now, another condition known as Horner syndrome, this is when you have damage to your sympathetic system. So sympathetics, again, remember, are innervating your sweat glands. If you don't have innervation to sweat glands, you can't sweat. And what's the purpose of sweat? Is to secrete out a fluid that allows you to cool off. If you can't secrete the fluid that allows you to cool off, you're going to get very hot. So you're going to have a very red and warm face on the side that is being hornered. So this is known as Horner syndrome. And what also will happen, you'll have partial ptosis. And why is that? It's because, or what is ptosis? Ptosis is a partial closure of the eye. You have complete ptosis if your eye is completely closed and you can't open it. That's usually due to cranial nerve 3 damage. But cranial nerve sympathetics control one small tiny muscle, and this is known as the superior tarsal muscle, and that allows it just for a little extra opening only, and that has to be in coordination with cranial nerve 3 that opens your eye. So if you lose this, you'll have partial ptosis, so partial drooping of the eye. If you can see this, it's a little bit drooping here. And then another thing is, what also does sympathetic do? Sympathetic also innervates dilation of your pupil. If you lose dilation of your pupil, then guess what happens? Your eye is constricted. The medical term for constriction of your eye is or your pupil is going to be miosis. So miosis. You also have that decreased sweating like we talked about. And this is usually due to Pancoast tumor. A Pancoast tumor is a tumor at the apex of your lung that ascends and metastasizes, damaging your sympathetic chain that comes up into your neck, your superior cervical ganglia. So definitely keep that in mind. Those are all possible answers when someone has these symptoms. Is where is this occurring? And you're thinking superior cervical ganglia is where those fibers that are controlling these things could be damaged. Next is trigeminal neuralgia. So this is a pain of your nerves, of the trigeminal nerve, so cranial nerve 5. So it's usually extreme V2 or V3 branches, so your cheeks and your upper lip or lower lip that this occurs in. It's not often your V1 branch or ophthalmic branch, but this is due to spontaneous pain or triggering of these nerves for some reason. Could be due to damage that you had on the face. Maybe somebody got beat up severely and the nerves never oriented themselves correctly back in place. So now they're stimulated by pain receptors to cause this patient this pain. This is something definitely need to be treating. Pain is something you must always treat for patients, but you also must assess them for it as well. Now, next is herpes zoster. So herpes zoster is really going to arise most often in your trigeminal ganglion, also cranial nerve 5 again. And this is, you've heard about this when your dermatomes herpes zoster. This kind of follows along in the same path as it's stored in the trigeminal ganglion until your immune system is latent when you're old and stuff like that. And if your immune system gets diminished, then your herpes zoster virus can break out and cause a lot of pain, and it ruptures along the trigeminal nerve branches, V1, 2, and 3. Fraze syndrome, although very rare, can happen. So if you just think phrase and fries, so like if you think of tasty fries, so what happens is you have your auricular temporal nerve, which does a little bit of sensory information, or sensory portion of the side of your face, also is important for sweating of the face. And what happens is, for some reason, instead of leading to salivation, if you damage those nerves, such as when you move your parotid gland or something like that, you can damage those nerves in the side of your face that then get re-innervated incorrectly. So if you have a nerve that usually would go down to innervate parasympathetics for salivation, so when you smell food and you think, oh gosh, like that is one delicious burger or one delicious pile of fries, phrase and fries, then you want to start salivating. However, if these nerves that cause salivation are hooked up to sweat glands instead, the patient will start to sweat when they start to smell food instead. So this is known as Fraze syndrome. Just damage to nerves and innervation hook up incorrectly. That's pretty much what Fraze is. Next is a little bit more details as far as trigeminal, cranial nerve 5, and facial nerve, cranial nerve 7. So cranial nerve 5 does sensory and motor, but it depends on the branch. So cranial nerve 5, V1 and V2 are primarily only sensory. They only do sensory. So you can see ophthalmic branch, this green, it's going to be the apex of the skull all the way down to the tip of your nose and the sides of your nose, except for the portion of the nose that you can flare. It also does your eyes and up to the side of your face here. So this is going to be your ophthalmic V1 branch of that. V2 does a little bit here, as well as this very lateral side of your nose, upper lip, and most of your cheek. That's going to be your maxillary, because you have your maxillary bone right here, so that makes sense. Then you have your mandibular, which can go up pretty high. It does not do the angle of the jaw, as you can see this. This is superficial cervical plexus. It does sensory there. It does not do the angle of the jaw, but it does do all the rest of your mandible, your chin, which is known as your genu, and your lower teeth as well. Your upper teeth are innervated by maxillary. And then this mandibular not only does sensory, but it also does motor. So the motor branch, or the motor branches of cranial nerve 5 or V3, innervate several muscles. So they're known as your mast mat. So MATT, mat, stands for the 4 muscles that are specific outside of your mastication muscles. So mastication is your chewing muscles. So that's going to include your masseter, it's going to include your lateral, pterygoid, which is important for opening your mouth, as well as the other pterygoid muscles. MAT is standing for mylohyoid, anterior belly digastric, tensor tympani, and tensor veli palatini. So both of those tensors are for trigeminals. So remember, if you ever think tensor, the T is for trigeminal, okay? Don't mess that up. Because next you're going to find out the levators. So the levator, when you come to hear about levator, it has a V, so it's going to be your vagus nerve. So remember that one day when you get to that nerve. And we'll get to that later in one of my other videos. Definitely check out those later videos. Next is your facial nerve. So your facial nerve has 5 branches. If you remember 2 zebras biting my cheeks, that's going to be important for, or two zebras bit my cookie. That's another one too. This is cranial nerve 7, facial nerve, and these are the motor branches. So as you can see, they orient exactly like that. So if you lay out your hand 1, 2, 3, 4, 5 on your face just like this, then those are all the branches. It's going to be your temporal branch up to your temporal. This is going to innervate muscles for your forehead, scrunching your forehead, lifting up your eyebrows. 2 is going to be for your eye. It's going to control closing your eye. 3 is going to be everything with your nose and your upper lip. So anything, movements that you can do to make facial expressions or flare your nose, it's going to be your your buccal branch. So zygomatic branch goes up to your eye. Buccal branch is for here, as well as your cheek. Marginal mandibular branch is for your mandible, your jaw, and your chin. And then your cervical branch goes down to your platysmus, so you can grimace. Now your ophthalmic manifestations. So you have several things. You have obviously loss of vision. It's going to be cranial nerve 2, your optic nerve, optic nerve, and your ophthalmic artery. Blood supply can help lead to loss of vision. Diplopia means double vision. That's usually only caused when you have misalignment. If you lose vision, you don't have diplopia because you can't see anything. You can't have diplopia without seeing something. Diplopia just means double vision, so you have to have vision, correct? So don't get tricked when someone asks you, oh, well, you have diplopia if you lose cranial nerve 2. No, that's wrong. However, you'll have diplopia if you have your eyes, or cranial nerve 2 intact, but your eyes are offset. You remember, both your eyes have to be in coordination of looking at the same image for you to see them clearly. If you cross your eyes, they're blurry, right? So what happens when you lose the muscles that control keeping your eyes aligned? So cranial nerve 3, 4, and 6. Those can all lead to diplopia. And so cranial nerve 3 is your oculomotor, cranial nerve 4 is trochlear, and 6 is abducens. So innervation for those, SO4, as we talked about, is your superior oblique muscle, and that's controlled by a trochlear, or cranial nerve 4. Your lateral rectus, LR, 6, is going to be your abducens nerve, cranial nerve 6, and all the rest are your cranial nerve 3. So what are all those muscles? Superior rectus, inferior rectus, and medial rectus, these guys right here, in addition to inferior oblique. Those are all cranial nerve 3. Superior oblique here is SO4, trochlear. Lateral rectus, for looking sideways, is going to be your 6, or abducens. So this is what's known as the H-test. You get to perform this and learn all about this, so I'm not going to go into further detail about this. There are wonderful resources online you can check out as well. So now a little bit about corneal and pupil reflex. This is something that's very important. You get to test it out in lab as well. You need to start understanding the different reflexes, afferents and efferents. So afferents is the sensory. So how do you sense something to trigger an efferent, or a motor function? That can be via parasympathetics, sympathetics, or via strict motor reflexes, such as your patellar reflex, if you hit your knee jerk, right? So you have your corneal pupillary reflex, and this is made of the afferent limb. So corneal reflex is something where you have to touch the cornea. So you have someone look up and away from the eye you're using. So if you're wanting to touch the right eye, you're going to have the patient look up and to the left. And you're going to approach from the side to touch their cornea, which is right over their iris with like a tissue. And what does the afferent limb is going to be sensory around your eyes. And remember, we talked about V1 branch of trigeminal controlling sensory over your eye. So that's going to be your afferent limb. Your efferent is going to be causing you to blink. And what branch was that? That's the zygomatic branch of cranial nerve 7. And that's going to control your muscle orbicularis oculi. And that will cause you to blink. So cranial nerve 5 and 7 for corneal reflex. For pupillary reflex, now it's light. So now you're thinking of vision. So vision is going to be your cranial nerve 2, your optic nerve, and causing you to constrict your pupil. So how do you constrict your pupil? Is via parasympathetics in cranial nerve 3, oculomotor. So this is going to control your sphincter pupillae and decrease your pupillary size. So those are the reflexes for that. Definitely you need to practice with your friends, shining lights in each other's eyes, and describing how, if you lesion one of these, how it will show up in a test. So if you damage cranial nerve 2 on the right side, how is this going to work? Well, that means there's no afferent limb on the right. So if I shine a light in their right eye, will their either eye constrict? No, because the afferent part doesn't get to trigger any of the efferent parts. However, if I shine light in the left eye on the same patient, their cranial nerve 2 on their left side is fine, and their cranial nerve 3 on both sides is fine. So since afferent, it will trigger both efferents, both eyes will constrict. So again, light in the right eye causes no constriction. Light in the left eye causes both to constrict. That's what it looks like when you have cranial nerve 2 deficit. So definitely practice with all those. That's super high yield. We had like 5 or 6 questions on our neuro exam straight from that. So for neuro exam purposes as well as your anatomy purposes, this is very, 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 very high yield. All right, and last but not least are your branches of your external carotid. So your external carotid actually has branches where your internal carotid doesn't. But your external carotid gives off several branches that is described as the mnemonic. Some anatomists like freaking out poor medical students, and they're listed here. Superior thyroid supplies your, obviously the superior part of your thyroid gland. A for ascending pharyngeal artery. L for lingual, which goes to your tongue. F for facial, goes to your facial, your face. O for occipital, goes to the back of your head. Posterior auricular goes behind your ear. S for superficial temporal, and maxillary, which was in there, medical students, Maxillary is going to be going to your cheek and your maxillar bone. Also, that gives off blood supply into your skull, such as your middle and accessory meningeals, where accessory meningeal goes through foraminal valve. So that's all the details as far as basics for here. Definitely check out our next cranial nerve our next cranial nerve videos, as well as our next head and neck videos that we have coming up.
MedSchoolTutors!
You're at SGU and you're thinking about Step 1. There are so many resources and so many opinions. How do you know which path to take? You've worked so hard and you deserve to match into the specialty of your dreams. MedSchoolTutors has helped nearly 1,000 SGU students get their best scores on their CBSE and USMLEs through highly personalized one-on-one tutoring and individualized advice. Our SGU students see average Step 1 score increases of over 30 points when working with us, scores that are their tickets to competitive residency spots around the country. Schedule your free phone consult today to be matched with your tutor. MedSchoolTutors. Get where you want to go.